My name is Minda Abebe from Hawassa University, College of Medicine and Health Science, Department of Anesthesia. I'm going to discuss about chronic rheumatic heart disease and pulmonary hypertension. As introduction, pulmonary hypertension is a phenomenon of increasing pulmonary artery pressure greater than 25 millimeter mercury when the patient is at rest, and if this value is greater than 30 millimeter mercury during exercise. Mitral and tricuspid regurgitations are some of the cardiac conditions that may develop during pregnancy. So, if the patient is coming to the hospital for Caesarean section with pulmonary hypertension and multivalvular heart disease, a careful preoperative assessment, a multidisciplinary involvement during the assessment is important, and goal-directed anesthetic plans is important to maximizing the cardiac function during the peripartum periods of the pregnancy. In addition to this, making informed decision about the mode of delivery, the anesthetic techniques with the family, the mothers, and the health professional is important for better outcomes of the mothers and the fetuses. When I come to the case presentation, our patient is coming to our hospital for elective cesarean section with chronic rheumatic heart disease and moderate pulmonary hypertension. She has one previous cesarean section 4 years back with an indication of macrosonemia. During that time, her cardiac condition was in moderate mitral regurgitation, mild left atrial dilatation, and mild pulmonary hypertension, and no tricuspid and aortic regurgitation. Since she was diagnosing this cardiac condition, she has a continuous follow-ups, but she didn't take any medication for cardiac condition. Now, during our preoperative periods, we heard the Graham still murmur on the left upper lobes during chest auscultation. In addition to this, third heart sounds of pansystolic murmur also heard on the apex area by the diaphragm of the stethoscopes by putting the patient in left lateral decompensated position. Here is the echo finding of the patient. The echo finding of the patient has severe left atrial dilatation, severe mitral regurgitation, mild aortic and tricuspid regurgitation with moderate pulmonary hypertension. After assessing the patient carefully in the preoperative and the preoperative periods in the laboratory investigations, we are taking informed consent from the mother and the family after discussing well about the risk and the benefit of surgery and anesthesia. Then we are transferring the patient to the operation theaters and applying the start and monitoring. After that, we intend to administer low dose of local anesthesia with opioids, and along with the trans-abdominal tap block or tap blockers. In this area, we are giving 7.5 milligram of bupropion plus 0.1 milligram of morphine along with tap blockers bilaterally before skin incision. The surgery was starting 15 minutes after tap block and 17 minutes after spinal anesthesia. The reason that we are selecting is a spinal neuralgial block for this patient is rather than general anesthesia. We haven't appropriate general anesthesia medication for this patient because we are living in the research limited area. The general anesthetic goal for this patient is with severe mitral regurgitation, severe left atrial dilatation, and pulmonary hypertension. The first one is preventing an increasing systemic vascular resistances, maintaining the high normal heart rate, maintaining sinus rhythms, treating acute atrial fibrillation if it occurs, avoiding autocaval compression in order to maintain the venous returns, avoiding any factors that increasing pulmonary hypertension is important to have a good outcome for the mothers and the fetuses. As a summary, anesthetic management is in such patient is challenging in resource limited area. A spontaneous delivery is recommended for patient with cardiac findings, but cesarean discharge may indicated in the area where limited access to support it is. In addition, that and an important thing is that we have to see in this patient is a goal-directed perioperative management with multidisciplinary involvement is as important and help to have a good outcomes of the mothers and the fetus. This is all. Thank you.